the show where we take complex biological systems and, well, we break them down. We look at how they work, why they matter, and what happens when that balance gets thrown off.
And today we are focusing on a tiny butterfly-shaped gland. It's located right at the base of your neck, the thyroid.
It's incredible, isn't it? It's the master regulator of your entire metabolic universe.
It really is. It weighs less than an ounce, but if its output speeds up or slows down even a tiny bit, it sends these huge systemic shock waves through your whole body.
We're talking about compounds that influence energy use, protein synthesis, the genetic expression of pretty much every cell you have.
It's the ultimate behind-the-scenes control panel. It's literally dictating your pace of life.
And our mission today is to pull back that curtain. We're doing a deep dive into the chemistry, the synthesis, the global actions, and crucially, the pretty sophisticated ways that modern medicine manages both deficiency and excess of these hormones.
And we are using a really robust stack of clinical and biological sources as our map for this.
So let's start at the beginning. Who are the players here?
Okay, so when we talk about the thyroid gland, we're talking about the secretion of three main hormones. You have thyroxine, which we just call T4.
T4, right.
Then there's triiodothyronine, or T3. And the third one is calcitonin.
But when most people, and our sources too, say thyroid hormone, they're really only talking about T4 and T3. Why is calcitonin the odd one out?
It's a complete biological separation. Calcitonin is chemically and functionally totally distinct from T4 and T3.
So it's made somewhere else.
It's made by different cells in the thyroid, these specialized C cells, and its job is strictly to regulate calcium metabolism, along with parathormone. It's part of the same system, the endocrine system, yes, but its function is entirely parallel.
So for today, we're just focusing on that metabolic duo, T4 and T3.
Exactly.
What I find so striking, especially knowing how absolutely essential these hormones are, is that their significance was recognized, surprisingly late. We're talking the mid-1800s.
It's a great example of clinical observation leading science. The early researchers, they understood the consequences long before they understood the cause.
So they saw the symptoms.
They saw the symptoms. You had observers like Graves in 1835 and Basout in 1840, and they were the ones who linked those severe symptoms like a rapid pulse, weight loss, bulging eyes, with the physical swelling of the thyroid gland. They named the disease.
And then you have the flip side, right? The consequences of deficiency.
Exactly. In 1874, a physician named Gull correlated the symptoms of myxoedema, that severe sluggishness, weight gain, thickened skin, with the gland actually shrinking with atrophy.
So they were describing hyper and hypothyroidism, but they had no idea what chemical was actually responsible.
None at all. That chemical identification was the real aha moment in hormone discovery.
It was a huge technical achievement.
A groundbreaking one. A guy named Kendall managed to get crystalline thyroxine, T4, in 1915, and its complex chemical formula wasn't confirmed until 1926.
Just think about the technology back then. Isolating a compound like that from tissue must have been a monumental task.
It was immense. And here's a fantastic little nugget from the sources. Thyroxine, T4, was the very first hormone ever successfully synthesized in a laboratory.
Wow.
Yeah.
That really underscores the complexity.
It's a massive historical milestone. But, even after they synthesized T4, they realized something was off. The purified compound couldn't account for all the biological activity they saw in whole thyroid extracts.
So something was missing.
Something was missing. And that biological gap prompted a search that lasted for decades, finally leading to the discovery of T3 in 1952.
And T3 turned out to be way more potent. It sets up this beautiful relationship where one hormone, T4, is sort of the quiet storage molecule for its more active partner.
Precisely. It fundamentally changes how we view T4. It's not the final product, it's really more of a delivery system.
Okay, let's move on to the factory floor then. If the thyroid is the factory, we need to understand the assembly line, starting with the raw materials. What are T4 and T3 actually built from?
So at their core, they're built from the amino acid tyrosine. Specifically, T4 and T3 are iodine-containing derivatives of a molecule called thymine.
And thymine itself is made from two tyrosine molecules fused together.
Exactly. So you have this carbon backbone from tyrosine, and then the factory just decorates it with iodine.
Yeah.
The names actually tell the whole story.
Right. T4 is tetraiodothyronine, 4 iodine atoms.
And T3 is triiodothyronine, 3 iodine atoms.
Yeah.
But the really key point about the thyroid factory is storage. The hormones aren't immediately released. They're synthesized and stored right there in the thyroid follicles as part of a gigantic scaffold molecule.
Thyroglobulin.
Thyroglobulin. It's
Oh,
this immense glycoprotein weighing around 660 kilodaltons. It's the entire synthesis and storage vault, all wrapped up in one molecule.
so it's like a massive protein chain with all the tyrosine residues pre-installed, just
Yeah.
waiting to get iodinated.
That's a perfect analogy. Which brings us to step one, getting the raw material. And this is a huge logistical challenge because iodine in the blood is, it's minuscule. We're talking zero point 0.2 to zero point 0.4 micrograms per deciliter.
So how does the body overcome that scarcity?
The thyroid uses an active transport superpower. It's called iodide uptake. Your entire body only has about 30 to 50 milligrams of iodine total, and the thyroid gland hoards about a fifth of that entire supply.
It's hoarding it.
It is. To overcome that incredibly low blood concentration, the thyroid cells use a special pump called the ni-iodide symporter, or NIS.
The NIS importer, and that's what actively sucks the iodide into the cell against the gradient.
Yes, it harnesses the energy from the sodium gradient to do it. And this process, which we call iodide trapping, is so spectacularly efficient that the concentration inside the cell can get over 100 times higher than in the blood.
100-fold. That's incredible.
It is. And this whole trapping mechanism is heavily stimulated by TSH, thyroid-stimulating hormone, which ensures that when your body needs more hormone, the iodine uptake is running at maximum capacity.
And here's that surprising fact from our sources. Other tissues have this NIS mechanism too. Salivary glands, mammary glands.
That's right. Skin, gastric mucosa, even the placenta, they all have this concentrating ability.
Yeah.
But here's the critical difference. In the thyroid, and only in the thyroid, is this mechanism stimulated and controlled by TSH.
Which gives the brain complete targeted control over it.
Total control. It prevents other organs from just, soaking up this essential resource when it's not needed.
Okay, so the iodide is trapped inside the cell. It then moves across into the colloid space through a transporter called pendrin. And that brings us to step 2, oxidation and iodination.
Right, and this is where the chemistry gets a little explosive. It's all catalyzed by a membrane-bound enzyme called thyroid peroxidase, or TPO.
TPO is the linchpin here.
It's the absolute linchpin. It uses hydrogen peroxide as fuel to oxidize the trapped iodide into these highly reactive forms of iodine.
And these reactive forms are then ready to combine with the tyrosine on the scaffold.
Yes. And what's interesting is that our sources note this combination happens non-enzymatically. It's spontaneous. The activated iodine just attaches itself to the tyrosine residues that are already sitting there on the giant thyroglobulin scaffold.
Decorating the scaffold.
Exactly. It forms monoiodotyrosine, MIT, and diiodotyrosine, DIT.
Yeah.
And this all happens while they're still bound to that thyroglobulin protein.
Which brings us to step 3, coupling. Now we have the decorated residues, the MIT and DIT, and they need to link up to form the final T3 and T4.
And this final assembly step is also catalyzed by that same powerhouse enzyme, thyroid peroxidase.
TPO again.
TPO again. It's an oxidative reaction. And this is where the sheer size and structure of thyroglobulin really pays off. It holds those iodinated residues in the perfect physical position to allow them to link up efficiently.
Then there's a nugget of biological genius here about what happens when iodine is scarce. The gland has a kind of a triage system.
It absolutely does. Normally, the synthesis pathway favors making T4. You make more DIT and couple them together. But if the body's deficient in iodine, the factory shifts its priorities.
How so?
Well, you'll have more monoiodotyrosine, MIT, available relative to DIT. And since T3 only needs 3 iodine atoms, the gland adapts by making a much greater proportion of the more biologically potent T3.
So it's maximizing the bang for its buck. It's getting the most biological activity out of the limited raw material it has.
It's metabolic triage built right into the biochemistry. You sacrifice quantity for potency when resources are low. It's a profound survival mechanism.
Okay, step 4 is storage and release. The finished product, the iodinated thyroglobulin, is stored in the colloid. But how does the gland know when to open the vault?
That is the TSH dance. Release is completely dependent on TSH stimulation. When TSH arrives, it signals the cells to pull the colloid back in through endocytosis.
And then it gets broken down.
Right. Once inside, lysosomal proteases just chop up the massive thyroglobulin molecule, freeing the T4 and T3.
And they're secreted into the circulation. What about the leftovers, the MIT and DIT that weren't used?
The system ensures zero waste. They are immediately deiodonated by a special enzyme, and that iodide is recycled right back into the process. It's a closed-loop system to conserve every single precious atom of iodine.
Our sources have this great visual cue for this. You can almost see the factory running in slow motion versus full blast.
Yes, if you look at the morphology of the cells, In a quiet resting gland, the follicles are full of colloid, like a big reserve tank, and the cells are flat. But under heavy TSH stimulation, the cells become tall and columnar. They're furiously pulling that colloid back in, and the colloid space virtually disappears.
The factory is running at full visible capacity.
Exactly.
So now we leave the factory floor, we hit the bloodstream. This is section 3, the circulation game. Daily secretion is pretty modest, right? 60 to 90 micrograms of T4 and only 10 to 30 of T3.
Right, but once they're in the blood, they need transport. These are highly lipophilic molecules. If they were just floating free, they'd diffuse out of the blood and get metabolized way too quickly.
Which brings us to this concept of avid protein binding. The vast majority is just hitching a ride.
Exactly. And here is probably the single most critical clinical point in this whole section. Only the tiny fraction of free hormone is biologically active.
How tiny are we talking?
We're talking less than 1/10 of 1% for T4 and less than 1% for T3. That's the only part that's available to act on cells or be excreted. The rest, the bound hormone, is just inactive storage.
So what are these crucial transport proteins?
There are 3 main ones in decreasing order of affinity for T4. The most important is thyroxine-binding globulin, or TBG. It carries the bulk of it.
Okay.
Then you have thyroxine-binding prealbumin, which is also called transthyretin. And third is just albumin, which provides general carrier capacity.
And this tight binding has huge clinical implications, especially when the body's hormonal environment changes, like during pregnancy.
It's a perfect example of how stable the homeostatic loop is. During pregnancy, estrogen makes the liver produce a lot more TBG.
So your total hormone level goes up.
Your total protein-bound iodine level shoots up, which might look concerning on a lab test. But because the negative feedback mechanism is so perfect, the body compensates, and the concentration of the free active hormone stays completely normal.
Which keeps the mother and the fetus in a normal thyroid state. It's all about the free fraction.
It's all about the free fraction.
Okay, now for the concept that really flips the whole paradigm, the T4 prohormone concept.
This is the realization that T4, the primary hormone circulating in your blood, is essentially just a transport form. It's a storage reservoir. It functions as a prohormone for T3.
And T3 is the actual active compound.
T3 is the one doing almost all of the genomic heavy lifting we'll talk about.
So where does this conversion happen? Where does T4 shed an iodine atom to become the more potent T3?
It happens peripherally, in target tissues all over the body, but primarily in the liver and the kidneys. About 1/3 of the T4 secreted every day undergoes this change.
So most of the active T3 in your blood didn't even come from the thyroid gland directly.
That's right. Most of it came from your liver converting T4.
And this conversion is handled by a very specialized family of enzymes.
Yes, the iodothyronine deiodinases, there are 3 of them, D1, D2, and D3. They are the gatekeepers that decide if T4 gets activated to T3 or deactivated into the inert reverse T3.
Let's break those down. What are their specific roles?
So D1 is mainly in the liver and kidney. It's kind of a workhorse, generating both active T3 and inactive reverse T3. But D2 is the interesting one. It's in highly sensitive tissues, like the brain and the pituitary gland.
And its job is just to make active T3.
Almost exclusively. And D3 is the deactivator. It's a brake. It only generates the inert reverse T3.
But what's really fascinating is that specialized role of D2 in the nervous system. The brain and pituitary are sort of insulated.
They are. They are so important for regulating the whole system that they don't just rely on whatever T3 is floating around in the blood. Instead, they actively take up T4 and convert it to T3 right there, inside their own cells, using D2.
That gives them immediate local control.
It ensures the regulatory centers have a consistent, locally controlled supply of the active hormone, no matter what minor fluctuations are happening systemically. It's a mechanism designed for pure stability.
And the power differential between these two is just immense.
Oh yeah, T3 is 5 times more potent than T4 at the receptor level, and it acts much faster. Its peak effect is in 1 to 2 days, compared to 6 to 8 days for T4.
So why is the majority of our circulating hormone the slow, less potent T4? Why not just secrete T3?
It comes back to that protein binding. T4 is 15 times more tightly bound to those plasma proteins,
Which gives it a longer half-life.
a much longer, more stable half-life of 6 to 7 days. If the body only secreted T3 with a short half-life of 1 to 2 days, the whole system would be prone to these rapid, dangerous swings. T4 provides the stability.
Okay, so once the hormones have done their job, how are they broken down and excreted?
The inactivation happens mostly in the liver. It's a 2-step process. First, more deiodination, and then conjugation.
Which is chemically tagging them to make them water-soluble?
Exactly. Adding a glucuronide or a sulfate group These tag hormones are then dumped into the bile.
But they don't just leave the body. Our sources mention an enterohepatic circulation loop.
That's right. A lot of those conjugates get dumped into the intestine, but enzymes there can actually remove the tag, allowing the hormone to be reabsorbed back into the circulation. It's a recycling system.
Another layer of conservation.
It contributes to their long half-lives before they're finally excreted in the urine.
That brings us to Section 4, actions and mechanism. Before we get into the profound effects on the cells, we need to quickly cover the regulatory structure, the feedback loop itself.
This is the classic hypothalamic pituitary thyroid axis, the HPT axis. The hypothalamus releases TRH, which tells the pituitary to release PSH.
And TSH is the accelerator for the thyroid gland.
It's the accelerator. And the thyroid hormones themselves, T4 and T3, are the brakes. They provide powerful negative feedback directly on the pituitary and the hypothalamus, shutting down TRH and TSH production when levels are high enough.
And that's what keeps the whole system in balance.
It's what prevents you from constantly running in either hypo or hyperdrive.
Okay, let's get to the mechanism of action. This is where we really confirm T3's role as the powerhouse. How does it manage to dictate the behavior of almost every cell?
So both T3 and T4 get into cells via active transport. But once inside, the action is all about the nuclear thyroid hormone receptor, the TR.
And this receptor is interesting because it's actively doing a job even when the hormone isn't there.
That is the critical distinction. In its inactive, unliganded state, the TR is already bound to the DNA, to a specific spot called the thyroid hormone response element, and crucially, it's bound there along with a complex of core pressors.
So in its default state, the receptor complex is a brake. It's actively suppressing gene transcription.
Precisely. It is physically standing on the gene's brake pedal, keeping it turned off.
Until T3 arrives.
When T3 enters the nucleus and binds, it acts as the key. The binding forces the TR to change its shape dramatically. It forms a dimer with the retinoid X receptor, which then causes the release of that inhibitory core pressor complex.
So it takes its foot off the brake.
And it binds a coactivator complex instead. That final shift is the signal that induces gene transcription, leading to the synthesis of all the specific proteins that drive the long-term metabolic effects of the hormone.
And this really confirms why T3 is the star. Our sources were clear that T4 has a much lower affinity for this nuclear receptor.
Much lower. And even if it does manage to bind, it can't activate or de-repress gene transcription successfully. This confirms, at a molecular level, that T3 is the primary active genomic hormone.
Let's move to the profound systemic actions then. Starting with growth and development, this explains why it's so vital early in life.
It is absolutely foundational. The classic visual is the metamorphosis of a tadpole into a frog. That massive remodeling, reabsorbing the tail, building lungs and limbs, is entirely controlled by thyroid hormone.
But the real-world clinical impact is seen in congenital deficiency, a condition called cretinism.
This is the most serious consequence. It leads to delayed developmental milestones, impaired myelination of nerves, and ultimately severe intellectual impairment. The developing nervous system is overwhelmingly dependent on this hormone.
And the sources highlight that even a mild deficiency during pregnancy can affect the fetus's neurodevelopment. The urgency for treatment is extreme.
It's a true emergency. Treatment with T4 has to start as early as possible, ideally within weeks of birth. And while the therapy is effective at restoring physical growth, the stark reality is that any mental retardation that has already occurred is only partially reversible. You are treating to prevent further damage.
Okay, next up, intermediary metabolism. We said these hormones don't fit neatly into the catabolic or anabolic box.
No, they're just metabolic accelerators across the board. Take lipid metabolism. Thyroid hormones potentiate catecholamines, which raises free fatty acids. But, critically, they dramatically accelerate the conversion of cholesterol into bile acids in the liver.
And that acceleration of cholesterol clearance is the key clinical sign of hyperthyroidism?
Absolutely. Hyperthyroidism is clinically characterized by hypocholesterolemia, low plasma LDL, because the liver is clearing it too fast. And conversely, hypothyroidism is a common hidden cause of high cholesterol.
What about carbohydrates?
Well, in hyperthyroidism, while tissues are using more glucose, this is completely overpowered by the liver breaking down stored glycogen and making new glucose. Plus, you absorb glucose faster from your gut. The net result is hyperglycemia. in a kind of diabetic-like state with insulin resistance.
And for protein metabolism, you get that classic sign of hyperthyroidism, tissue wasting.
The overall effect is catabolic. You see this profound tissue wasting and a negative nitrogen balance because the body is literally consuming its own muscle mass for energy.
Now, calorigenesis, this is the big one. The massive increase in energy burn.
This is the defining characteristic. It's the increase in your basal metabolic rate, or BMR. The hormones essentially reset your body's energy stat to a higher level, which is crucial for maintaining body temperature.
And the cardiovascular system is maybe the most dangerous system affected by too much thyroid hormone, this hyperdynamic state.
The system is forced into overdrive. You get a sustained increase in heart rate, contractility, and cardiac output. The hormones have a direct effect on the heart muscle, making it contract harder and faster.
And then there's the indirect effect, the nervous system sensitization.
Yes, they upregulate the beta-adrenergic receptors on the heart, making it hyper-responsive to circulating adrenaline. The result is a fast, bounding pulse, high blood pressure, and a really high risk of serious arrhythmias, especially atrial fibrillation.
The effects on the nervous system really define the patient's psychological state.
Profoundly. In hyperthyroidism, the patient is anxious, nervous, exhibits fine tremors, hyperreflexia. They can't sit still. In hypothyroidism, it's the complete opposite. Sluggishness, mental impairment, apathy. The mind's operating speed just grinds to a halt.
And a lot of those physical symptoms, the tremor, the racing heart, are driven by that final action, adrenergic sensitization.
This is the unifying concept. Many of the signs are caused by the body's own normal levels of adrenaline having an overwhelming, exaggerated effect.
So T3 and T4 don't replace adrenaline, they just make the body scream whenever adrenaline shows up.
That's a perfect way to put it. The volume is turned up to 11. You are hyper-responsive to your own normal physiological stress.
Okay, we've established the vital function of these hormones. Now we turn to medicine. Section 5, managing deficiencies, replacement therapy. For patients whose thyroid is failing, what is the drug of choice?
The standard worldwide is synthetic L-thyroxine sodium, T4. You see it branded as L-troxin or Thionorm.
Now, why choose the less potent, slow-acting T4 for routine use instead of the active T3?
It's all about those pharmacokinetics we discussed. T4 provides a highly sustained, uniform action because of its long half-life and tight protein binding. That consistency dramatically lowers the risk of causing dangerous cardiac arrhythmias, which is a huge concern, especially in older patients.
So let's talk about the key uses, starting again with cretinism.
Right. Congenital hypothyroidism, cretinism, and mandates immediate T4. And we have to reiterate, you are treating to prevent further mental damage. That window of opportunity for proper neurological development is incredibly narrow.
Moving to adults, hypothyroidism is extremely common.
Yes, adult hypothyroidism or myxoedema is often an autoimmune condition called Hashimoto's. The treatment is very effective, but the approach demands extreme caution.
You mean with the dosing?
The dosing sensitivity is paramount. In a young, healthy patient, you can start with a near full dose. But in anyone over 50 or anyone with heart disease, the initial dose has to be tiny. Like 12.5 to 25 micrograms a day. And you increase it painstakingly, gradually, every few weeks to avoid triggering angina or heart attack. You're slowly reintroducing the accelerator to a system that has learned to run in low gear.
And the goal is to normalize the TSH level.
Exactly. When serum TSH is normal, you know you have the right dose.
We also have this gray area, subclinical hypothyroidism.
Right. This is when your free T4 is normal, but your pituitary is struggling, so your TSH is high, usually above 10. Treatment with T4 is definitely required then.
And what if it's a little lower, say between 6 and 10?
Treatment is still usually preferable, especially if the patient has other cardiovascular risk factors. It can prevent progression to the overt disease.
The most acute need is myxoedema coma, a true endocrine emergency.
It's acute, severe hypothyroidism with a high mortality rate. Rapid replacement is crucial. The protocol is a big IV loading dose of L-thyroxine, 200 to 500 micrograms.
So you still use T4, not T3, even in an emergency.
Still T4, because of the high cardiac risk in an already fragile patient, and the care is broader. External warming, IV corticosteroids for potential adrenal failure, and full cardiovascular and ventilatory support.
And finally, non-toxic goiter. This seems counterintuitive, giving T4 to someone who is clinically euthyroid.
This is a clever use of the negative feedback loop. The goiter, the enlargement, is caused by TSH overstimulation because the thyroid is struggling to make enough hormone.
So the TSH is driving the gland to grow bigger to compensate?
Exactly. By giving external T4, you artificially suppress the TSH. You remove the stimulus for growth. In recent diffuse goiters, this can cause the gland to actually shrink.
So before we move on, what are the practical considerations for taking L-thyroxine?
Consistency and absorption. It has to be taken on an empty stomach. And things like food, iron supplements, calcium, and proton pump inhibitors all bind the hormone in the gut and dramatically reduce its uptake. Patients have to take these things hours apart from their T4.
Okay, let's flip the script. Section 6, managing excess, thyroid inhibitors. First, what causes thyrotoxicosis?
The vast majority is Graves' disease. It's an autoimmune disorder driven by an antibody, the thyroid-stimulating immunoglobulin.
And this antibody mimics TSH.
It binds to the TSH receptor and stimulates the thyroid relentlessly, completely independent of the body's actual needs. So your own TSH is zero, but the gland is in overdrive from this rogue antibody.
The other major cause?
Toxic nodular goiter, usually in older people. You get these autonomous nodules in the gland that just start pumping out hormone on their own, independent of TSH.
So the goal of the inhibitors is to lower the functional capacity of this runaway gland. First up are the thioamides.
Right. These are drugs like propylthiouracil or PTU and methimazole. Their mechanism is direct chemical intervention right on the factory floor. They target that TPO enzyme.
And they block the two critical steps of assembly.
They bind to TPO and prevent, 1, the iodination of tyrosine, and 2, the coupling of those tyrosines to form T3 and T4.
So the factory can't make new hormone.
Exactly. But this is why their effect is delayed. They do nothing to block the release of the huge amount of hormone already stored in the colloid. So it takes a week or two for the effects to really kick in.
And there's the crucial difference between PTU and methimazole.
There is. PTU has a dual mechanism. In addition to blocking synthesis, it also inhibits the peripheral conversion of T4 to T3. Methimazole doesn't do that.
So what's the long-term goal with these drugs?
For Graves' disease, they can be a definitive therapy. Up to half of patients, especially younger ones, can get a long-lasting remission after a year or two of treatment. They're also essential for preoperative prep to get a patient euthyroid before surgery.
What about the adverse effects?
Well, you can cause hypothyroidism if you overtreat, but the big scary one is a granulocytosis, a severe drop in white blood cells. It's rare, about 1 in 500 cases, but it's life-threatening. Patients have to be watched very closely.
And when is PTU specifically preferred?
In 2 acute situations. First, early pregnancy, because it crosses the placenta less readily. And second, in a thyroid storm, because that extra action of blocking peripheral T4 to T3 conversion gives you the fastest possible reduction in the active hormone.
Next, we have one of the great paradoxes in endocrinology, using iodine and iodides to treat hyperthyroidism. How does the building block become the inhibitor?
It's called thyroid constipation. A large dose of iodine slams the brakes on 2 things. First, it immediately inhibits hormone release. It just halts it. Second, it temporarily interferes with synthesis, which is known as the Wolff-Chaikoff effect.
It stops secretion cold.
It does. The effects are immediate and dramatic. But here's the problem. The effect is transient. After 10 or 15 days, thyroid escape occurs, and thyrotoxicosis can come roaring back.
So given that it's temporary, what are its clinical uses?
2 very specific high-stakes uses. First, for about 10 days right before surgery for Graves' disease. It makes the gland firm and less vascular, which makes the operation much safer.
And the second?
Thyroid storm. A solution like Lugol's iodine is used to rapidly stop any more hormone from being released, buying time for the other drugs to work.
Okay, on to the third option, which is destructive thyroid. Radioactive iodine, I-131.
I-131 is a miracle of targeted therapy. It's chemically identical to normal iodine, so the hyperactive thyroid gland traps it just as efficiently. But I-131 is an isotope that emits beta particles.
And those beta particles are the ideal weapon.
They are, because they have incredibly poor tissue penetration, only about a millimeter. So the radioiodine gets concentrated inside the follicle, and the beta particles destroy the hyperactive cells from the inside out, without damaging any neighboring tissues. It's a chemical scalpel.
So when is this used, and what's the major trade-off?
It's often the treatment of choice for hyperthyroidism, especially in patients over 25. The advantages are clear. It's simple, cheap, no surgical risk, and the cure is permanent.
But the long-term cost is almost guaranteed hypothyroidism.
That is the major unavoidable drawback. The destruction is progressive. About 5 to 10% of Graves' patients become hypothyroid every single year after treatment, and they'll need lifelong T4 supplementation.
So it solves one problem but usually creates the opposite one.
It does, and critically, it's absolutely contraindicated in pregnancy. It will cross the placenta and destroy the fetal thyroid, causing irreversible cretinism.
Finally, we have adrenergic blockers. These offer symptomatic relief but don't attack the root cause.
Propranolol, a non-selective beta blocker, is the key drug here. Its role is palliative. It alleviates those intense symptoms driven by sympathetic overactivity, the palpitations, the tremor, the nervousness.
So it's used to make the patient comfortable while waiting for the thiamides or the radioiodine to work.
Exactly, it's a stopgap. But its most critical role is in thyroid storm, where it is often the single most valuable measure. It affords dramatic, symptomatic relief and can prevent cardiovascular collapse.
Okay. We have successfully navigated the entire journey of this hormone, from trapping iodine to its role as the master genomic regulator, and the therapies used to manage imbalance.
It really illustrates the tight balance required. We saw iodine trapped 100-fold, incorporated into thyroglobulin, released, and then peripherally converted into T3, the nucleus-binding key.
We spent a lot of time establishing T3 as the primary active genomic hormone, the one that enters the nucleus, binds the receptor, and flips the master genetic switch.
And we concluded that T4 is mainly a prohormone, a stable, long-lasting reservoir for that active T3.
But our sources had a fascinating caveat that should make us question that conclusion, which leads to our final provocative thought. While T4 is weak at the nuclear receptor, the sources noted it's equivalent to T3 at two other critical sites, the cell membrane and the mitochondria.
Right, where it enhances things like glucose entry and oxygen consumption. These are rapid, non-genomic actions. They are immediate cellular effects that completely bypass the slow process of gene transcription.
It's a question of speed versus depth.
It is. If T4 can't really activate that master genetic switch, how significant are these fast-acting non-genomic effects that happen at the cellular periphery? Could T4 be driving essential, immediate cellular behaviors like accelerating energy usage, completely independent of T3?
So we might be underestimating T4's role. It's not just a passive transport vehicle, but maybe a fast-acting player that controls the immediate energy needs of the cell.
While T3 handles the long-term genetic programming, it forces us to ask if T4 is really just a prohormone or something much more.
Is the prohormone secretly an equally active but faster-paced player? A challenging thought to end on, but one that drives future research.